Welcome to the deep dive. We're here to, break down complex topics into something much easier to grasp.
Making things clear and useful.
Exactly. And today we're tackling monoclonal gammopathy of undetermined significance, MGUS.
Right, MGUS. Sounds a bit intimidating, maybe.
It really does. But that's what we're here for, to make it clear, maybe even a little less daunting. We'll cover what it is, what it means, basically get you in the know.
Using the key info, yeah.
Yeah.
What it is, causes, risks, how it looks long-term, the whole picture.
Okay, let's dive right in then. What, in simple terms, is MGUS?
So basically, MGUS is a condition, a non-cancerous one. The main thing is finding an abnormal protein in the blood. It's called an M protein or sometimes paraprotein.
An abnormal protein.
Yeah, and this is really the key point for MGUS. It's there without causing any symptoms, any real problems or organ damage.
Okay, no symptoms, no damage. That sounds relatively good.
It is, relatively speaking.
Yeah.
You might also hear it called benign paraproteinemia or monoclonal gammopathy, just different labels for the same underlying thing.
Got it. So this M protein or paraprotein, what exactly is that? Where does it come from?
Okay, think about your immune system. It makes antibodies, immunoglobulins, right, to fight infections. Plasma cells in your bone marrow make these.
Right, the antibody factories.
Exactly. Now, usually you make lots of different types, but sometimes one single type of plasma cell, a clone, starts multiplying more than it should.
Oh, okay.
And this clone produces just one specific type of immunoglobulin, or maybe just a part of one, like a light chain. That specific overproduced protein is the paraprotein.
So it's like one factory machine going into overdrive.
That's a good way to put it. It creates an imbalance. And importantly, MGUS is sort of on a spectrum. At one end, you have MGUS, which is benign.
And at the other end?
At the other end are more serious conditions like multiple myeloma, where those plasma cells are actually cancerous and cause damage. So MGUS is like an early warning sign, potentially.
Okay, that spectrum idea helps place it.
Mm.
So what actually causes these plasma cells to start overproducing in MGUS? What's the etiology?
Well, the exact why isn't fully pinned down. We know it involves this abnormal growth, this proliferation of plasma cells in the bone marrow.
But not why they start growing abnormally.
Not precisely. The initial trigger is still under investigation.
Mm-hmm.
We do know it's not, for instance, just a lab artifact like using a heparin tube by mistake that can cause a false positive sometimes, but that's not true MGUS.
Right, so it's a genuine biological process. Now, you said MGUS is defined by not causing problems.
Yeah.
What are the specific criteria doctors use to say, okay, this is MGUS, not myeloma?
Yeah, there are key features. First, the amount of that paraprotein in the blood is relatively low. Usually the threshold is less than 30 grams per liter.
Okay, low protein level. What else?
Second, if they do a bone marrow biopsy, the percentage of these plasma cells should be low, less than 10% of all the cells there.
Less than 10%, got it.
And third, probably the most crucial one, there must be no signs of myeloma-related organ damage. Remember the CPRAB criteria?
Yes, CRM. Remind us.
Sure. C is for high calcium levels. R is for renal insufficiency, so kidney problems. A is for anemia, low red blood cells. And B is for bone lesions, like holes or weak spots.
So for MGUS, you need low protein, low plasma cells in the marrow, and no CAB features.
Exactly. That combination points towards MGUS rather than active myeloma or another related disease. It's also really common in older people and usually doesn't need treatment straight away.
Right, but it does need watching.
Absolutely. Monitoring is key because of that small risk, about 1% per year, that it could progress to myeloma later on.
Okay, let's talk about risk factors then. Who's more likely to get MGUS?
Age is the biggest factor. It's much more common in people over 50, and the chances increase the older you get.
Over 50. What else?
It's also seen slightly more often in men than in women, and having a family history, a relative with MGUS or myeloma, can increase the risk a bit.
Family history, okay. Any other factors?
Some genetic abnormalities, like certain trisomies having an extra chromosome, have been linked, and there's some association with exposure to certain things like pesticides, chemicals, or radiation, though the links aren't always super strong.
So main ones are age, being male, and family history. Interesting. Let's go back to the mechanism, the pathophysiology. What's happening at the cellular level?
It really boils down to that clonal proliferation of plasma cells we mentioned. One cell develops some kind of change, we don't know exactly what, and it starts dividing more than normal.
Creating a clone army.
Sort of, yeah. And all these identical cells pump out that same monoclonal protein, the paraprotein. Why that initial cell goes rogue in MGUS rather than becoming fully cancerous like in myeloma is still a bit of a mystery we're trying to solve.
Still pieces missing in the puzzle. Okay, so if someone presents with this paraprotein, what other conditions do doctors need to rule out before landing on an MGUS diagnosis, the differential diagnosis?
That's a really important step. Because MGUS is benign, you have to make sure it's not something more serious hiding behind it. Multiple myeloma is top of the list, obviously.
Right.
But also things like Waldenstrom, microglobulinemia, that's another type of blood cancer involving a different protein, IgM usually. Other lymphoproliferative disorders, too.
Like lymphomas or leukemia?
Potentially, yes. Also, amyloidosis, where the protein deposits in organs and causes damage. Chronic lymphocytic leukemia, CLL, can sometimes have a paraprotein. And even just reactive increases in plasma cells due to, say, chronic infection or inflammation.
So quite a list to consider.
It is. It requires careful investigation to exclude those before confirming MGUS.
And how common is this finding? You mentioned it increases with age. What are the actual numbers?
The data suggests that if you screen people over 50, you'll find a paraprotein in about 3.2% of them.
Wow, over 3%. That's surprisingly common.
It is, yeah. And that figure definitely climbs higher in the 70s, 80s, and beyond. And as we said, consistently a bit more common in men. So, it's something GPs and specialists encounter quite regularly.
Okay. Now, you said earlier MGUS usually has no symptoms. Is that always the case?
Mostly, yes. That's kind of the definition undetermined significance, because it's not causing obvious problems. It's often an incidental finding on routine blood work.
But are there any potential symptoms, even rare ones?
There is one notable exception. About 10 to 30% of people with MGUS might develop a specific type of nerve problem called demyelinating neuropathy.
Neuropathy, what does that feel like?
It can cause things like numbness, tingling, sometimes weakness or balance problems, often starting in the hands or feet. So while MGUS itself isn't felt, this associated neuropathy can cause noticeable symptoms in a minority of people.
That's important to note. Now, the notes also list a whole bunch of other symptoms, things like fatigue, bone pain, kidney issues. Are these MGUS symptoms?
Ah, right. That's a bit more nuanced. Those symptoms aren't typically caused by the MGUS itself. Instead, they are reasons why someone might get investigated in the first place, leading to the discovery of a paraprotein.
Okay, so they are red flags that might trigger testing.
Exactly. If someone has, say, persistent, unexplained back pain or strange kidney results or fatigue and anemia, those C-crab symptoms we talked about, a doctor might check for a paraprotein.
I see.
Then the investigation starts to figure out why the paraprotein is there. Is it MGUS or is it myeloma causing the bone pain or kidney issues?
So the list: malaise, bone disease, renal issues, anemia, high calcium, infections, hyperviscosity symptoms like headache, nephrotic syndrome, heart failure, neuropathy, even just high ESR. These are clinical indications to look for a paraprotein.
Precisely. They aren't direct symptoms of MGUS, but they are triggers for the diagnostic process that might lead to an MGUS diagnosis or perhaps something more significant.
That clarifies things. So let's focus on differentiating MGUS from myeloma again. What are the absolute key differences to remember?
Okay, let's nail this down. First, immune function. Generally normal in MGUS, often suppressed in myeloma, leading to infections.
Right.
Second, beta-2 microglobulin levels, usually normal in MGUS, often elevated in myeloma.
Okay.
Third, the paraprotein level itself. Lower in MGUS, typically under that 30 GL for IgG or 20 GL for IgA, whereas it's often much higher in myeloma.
A lower level. Makes sense.
Fourth, stability. The paraprotein level in MGUS tends to stay stable over time. In myeloma, it usually rises.
Stable versus rising. Crucial.
And finally, the big one, the absence of those myeloma clinical features, the C-crab criteria we keep mentioning. No lytic bone lesions, no significant kidney disease caused by the plasma cells, etc.
So normal immunity, normal B2M, lower stable protein, no crab.
Yeah.
That's the MGUS picture.
You've got it. That's the core distinction.
Perfect. So what tests do we actually run to diagnose it? You mentioned blood tests.
Yes, the key ones are in the blood. Serum protein electrophoresis, SPEP, that's the one that shows the spike, the M protein band.
SPEP for the spike.
Then, immunofixation electrophoresis, IFE. That tells you the exact type of the M protein, like Ig kappa or IgA lambda. It identifies it.
IFE identifies.
Got it. And the serum-free light chain assay. This measures those light chain components floating free in the blood, which can be abnormal, even if the main SEP looks okay sometimes.
Okay, SPEP, IFE, free light chains. Are those usually enough?
Often they are the starting point, but depending on the results and the clinical picture, more tests might be needed.
Like what?
A bone marrow biopsy is quite common, especially if the M protein level is higher or if there are other concerning features. That checks the percentage of plasma cells directly.
Checking the marrow itself.
Yep. And imaging a skeletal survey, x-rays of major bones, used to be standard. Now, sometimes more sensitive imaging like low-dose CT, MRI, or PT scans might be used to look carefully for any bone damage.
Looking for those B features in crab.
Exactly. And crucially, testing urine for Bence-Jones protein, those free light chains again, is also very important. Some myelomas might only show up in the urine.
So don't forget the urine test.
Definitely test both blood and urine. So for a quick memory aid for investigations, SPEP, IAFE, serum free light chains, maybe bone marrow biopsy, urine test and imaging, maybe. SIL-BUI, bit clunky maybe.
Haha, maybe. Or just remember the core blood tests. SEP, IFE, FLC, and then add bone marrow, urine, and imaging as needed.
That works too. The key criteria for differentiating benign MGUS are basically no bone marrow disease seen on biopsy, low plasma cells, low and stable M protein level, no significant light chains in the urine, and usually normal levels of the other immunoglobulins.
Right. Okay, so someone gets diagnosed with MGUS. What happens next? What's the management?
Well, for the vast majority of the management is no treatment.
No treatment at all.
Not for the MGUS itself, no. Because it's benign and not causing problems, the focus is entirely on monitoring.
Ah, the watchful waiting you mentioned earlier.
Exactly that. Regular follow-up with blood tests, checking the M protein level, blood counts, kidney function, calcium, and clinical examinations.
Now, how regular is regular?
It varies depending on the initial risk assessment, things like the M protein level and type, the free light chain ratio. It might be every 6 months initially, then maybe annually if things are stable. The goal is to catch any potential progression early.
And if it does start to progress towards myeloma or something else?
Then at that point, specific treatment for that developing condition would be initiated. But the MGUS itself doesn't get treated preemptively.
Okay, monitoring is key. What about the long-term outlook, the prognosis?
Overall, the prognosis for MGUS itself is very good. Most people live a normal lifespan without it causing major health issues directly.
That's reassuring.
The main thing to keep in mind is that lifetime risk of progression. We said about 1% per year.
Right, 1% annual risk.
So while the prognosis for MGUS is good, the prognosis changes if it progresses to myeloma. For context, the 5-year survival for myeloma itself was around 52% based on 2020 data, which highlights why monitoring MGUS is important, even though the risk of progression is relatively low each year.
So good prognosis for MGUS itself, but vigilance needed for that potential progression. What are the main complications then? Is it just that risk of progression?
That is by far the main complication. The risk of it transforming into multiple myeloma, Waldenstrom macroglobulinemia, amyloidosis, or another related lymphoproliferative disorder over time.
That's the big one to watch for.
Absolutely. That's the entire rationale behind the long-term monitoring strategy, to detect those signs of progression early when treatment is likely to be more effective.
Are there any statistics on how often that progression happens over longer periods?
Yes, some studies suggest around 10% of people with MGUS might progress within 10 years. And maybe some figures go higher over much longer follow-up, perhaps towards 50% over 15 years in some cohorts. But that varies a lot depending on the study and the initial risk factors.
So the 1% per year adds up over decades.
It does. It underscores why lifelong follow-up is generally recommended for most people with MGUS.
Okay, so let's summarize the key takeaway. MGUS, pretty common, especially over 50. It means you have this specific abnormal protein, M protein, in your blood.
Right. But crucially, no symptoms or organ damage directly from it in most cases. Maybe that neuropathy sometimes.
And because there's that small but real long-term risk, about 1% per year, of it turning into something more serious like myeloma.
Regular monitoring, blood tests, checkups, that's the standard approach. Watchful waiting.
It really highlights the importance of understanding these conditions, even the ones labeled undetermined significance, and just staying informed about your own health.
Absolutely. Knowledge empowers you in discussions with your healthcare team.
Well said. And if you, the listener, want to delve deeper into this or other medical topics for revision or just general knowledge, definitely check out PastMSRA.com.
And there's also freemsra.com for fantastic free resources too. Really helpful for medical exams and learning.
Great resources. Well, that wraps up our deep dive on MGUS. Thanks for joining us.